Hi, everyone. Good afternoon. Is everybody able to hear me okay? I'll try a little bit louder for the back. There's a thumbs down. If anyone's with us. So welcome. I am very, very happy to be with you today. And thank you for your presence and attention as we close out today's session. We'll be talking about trauma-informed clinical care and how that can impact our care of patients, as well as our own experience in the healthcare system. So I have no disclosures to report. And while I will not be showing any audiovisual depictions of trauma today, if any portion of our conversation feels uncomfortable, please just take care of yourself in whatever way that you need. And our objectives are to first define trauma and trauma-informed care, which may or may not be a new concept for you, to apply key principles of trauma-informed care to clinical care as we see patients, but also understand how this kind of an approach to our holistic health can help cultivate our own resilience and ability to stay in this profession, as we've been discussing this afternoon. So first, we'll think about an overview of trauma. It's a big word. It's a heavy word. It's a poorly understood word. I'll share how I got into this field. My first job out of my training was at the VA, and I realized quickly that there were very basic physical exam procedures that I was doing in the room that were making my patients visibly distressed. I remember swinging my stethoscope off my neck to start the cardiac exam, and the patient jumped. I remember approaching someone for the thyroid exam, and he stammered back. And so slowly I started adjusting my language, where I stood in the room, how I approached the patient, just in an effort to set them at ease. And I started teaching those strategies to medical students. And one day a student asked me, hey, Dr. E, can you tell me more about your trauma-informed techniques? And I was like, trauma what? I thought she just made up that term. I'd never heard of that before. And she told me that trauma-informed care is actually a very well-established framework for supporting people who've experienced various forms of trauma. And we can apply these principles universally as a means of building resilience. She also shared that through this perspective, healing happens through people. It's through safe and collaborative relationships, which is really beautiful if you think about it, because any interaction you have with someone else can be seen as an opportunity to reverse the impact of trauma. And I thought, oh my God, why has nobody told me about this before? I thought I went to pretty good schools. I was raised by academic medicine. That was my parent. And nobody thought to teach me this. So I was completely enthralled. I read everything that I could about trauma-informed care and developed a formal framework for a trauma-informed physical exam, which is now being taught at med schools across the United States. And so it's been an interesting and exciting journey. And in this time where stress levels have become quite toxic in the world, this is a social movement that is ever increasing. So Oprah wrote a book with Dr. Bruce Perry, who's a world-renowned traumatologist. It's called What Happened to You? And it's firmly rooted in these principles. Kaiser released a change package to make their primary care clinics trauma-informed. We have ASA's Aware, which is an advocacy group led by the U.S. California Surgeon General about adverse childhood experiences. And then trauma is popping up everywhere in popular media. So it's a ripe time to be thinking about this work. What is this word, trauma? Many definitions. I like this one because it's simple and catchy. These are the 3 E's. It's any event that is experienced as harmful and has lasting adverse effects on well-being. So pretty broad, it can be lots of things. SAMHSA is a pioneer in this field. It's the Substance Abuse and Mental Health Services Administration. So thinking a little bit further, there are so many experiences from the individual all the way up to the societal levels that have the potential to be perceived as deeply stressful. This is not surprising. We live in this world. Here are some examples. We have many forms of discrimination, various forms of violence and abuse, including the adverse childhood experiences, or ACEs, that I just mentioned, transgenerational trauma, including war, natural disasters like pandemics, and then the medical trauma, physical trauma, issues related to social determinants of health that we see all day long. So trauma is not just a broken bone, like some physical injury, like we used to think. Trauma is not something that only happens to our patients. If you scan this list,
These are very common, very human experiences. Trauma impacts all lives. How can this impact clinical care? I'd like to lead you today through the 4 R's of a trauma-informed approach, also by SAMHSA. The first R is to realize the widespread impact of trauma. Number 2 is to recognize the signs and symptoms of trauma among patients, families, staff. To respond by putting trauma-informed principles into practice, and finally resist re-traumatization. So we'll start with the first R of realizing the impact of trauma, and for that I'll show you some basic stats. One national study estimated that 89% of people living in the US will experience at least one traumatic event in their lifetime. So this is kind of a near universal experience of our mortal lives. And trauma can take away one's sense of safety and autonomy and trust. And so when I am entering into the exam room, I think, how can I help this patient feel more safe? How can I give them more of a sense of control and agency? And how can I help them feel more trusting of the environment and the healthcare team? So let's think a little bit about ACEs, because this is the most famous foundational study ever published in the world of trauma. This is from the 1990s, and they surveyed thousands of Americans, asking them whether they had ACEs before the age of 18 in these categories: neglect, abuse, and household dysfunction. And what they found was that over half of people had at least one ACE. And this work has been foundational, but since that time, more work has expanded upon ACEs to include more structural exposures to adversity, like community violence and racism. So this is an underestimate. Fast forwarding in the study, individuals with 6 or more ACEs died nearly 20 years earlier. And this is why trauma experts are calling early childhood adversity the single most important predictor of lifespan. So how does adversity contribute to morbidity and mortality? This is the ACE pyramid, and at the bottom are the historical, social, economic factors that influence our lives and our health. And then when you add adversities on top of that, that actually changes the neurodevelopment of the brain. And we see an increase in adrenaline and norepinephrine and cortisol, and all of that leads to increased inflammation in the body and impaired immunity and altered metabolism, which can influence disease, especially in the context of depleted psychosocial resources. On top of that, we have perhaps some maladaptive coping behaviors that we use to deal with stress, maybe disordered eating behaviors, maybe substance use disorders. And so all of this is a big cycle that impacts disease. I don't want anybody to go home and calculate their ACE score and think they're dying tomorrow. This is not how that works. ACEs are not as predictive of mortality on an individual level. There are also PCEs, positive childhood experiences, that serve as a buffer for this. So it's all complex. Healthcare, adversity and trauma in healthcare. Healthcare is a trauma playground, especially where I work at the VA with veterans. About a third of patients on my panel have PTSD. Think about it, many of the procedures and surgeries that we offer are nerve-wracking and cause pain and real psychic distress as well, impacts families and communities. There are loud noises and sounds and things that are confusing, the things that we witness to all day long as healthcare professionals. I mean, trauma is an occupational hazard of our jobs. So number 2, the second R, is to recognize the signs and symptoms of trauma. So let's think about how this shows up. What does trauma look like in our patients? It can show up in many ways. Maybe there's avoidance of routine primary care, especially where there are sensitive procedures planned, like pap smears, colonoscopies, et cetera. Maybe they're no-showing or canceling their appointments, especially when a sensitive procedure is planned. We see a lot of agitation, a lot of aggression. There's been a surge since the pandemic in the secure messages that we get in our online patient portal. And patients are so angry in those messages. Maybe vague chronic symptoms that are unexplained despite extensive workup, avoiding telling you that maybe they're having rectal bleeding because that would prompt an invasive test, appearing nervous or distracted when you speak with them, or not adhering to treatment, and maybe they have severe chronic multi-organ disease like stents in every peripheral artery despite only being 50 and smoking a packet. What does trauma look like in us? How does it impact us in the workplace? This is a quote I'm going to read from Dr. Bessel van der Kolk, who is the most famous psychiatrist in the world right now. His book, The Body Keeps the Score, has been #1 on the bestseller list for a while. And he says that there are many signs and symptoms. Most noticeable at work would be a struggle to focus, forgetfulness, chronic fatigue, withdrawal, lack of enjoyment, irritability, emotional dysregulation, intense need to control, hypervigilance, panic attacks, perfectionism, inability to relax, overworking. Nobody here overworks. Poor time management, frequent sick days, and behavioral extremes. So if you think about this list, have you seen any of these signs and symptoms in your coworkers? Have you noticed any of these things in yourself? Stress occurs along a continuum, and perhaps you wouldn't describe yourself as a trauma survivor, but there's positive stress, there's tolerable stress, and then there's toxic stress. So let's just be mindful of that. I really, really love this paradigm. This is a key tool in the world of psychology. It's called the window of tolerance. And we all aim to stay in this middle zone of optimal arousal where we can think and act clearly at work. But sometimes something activates us to move up out of the window into hyperarousal, where we're seriously on guard and tense and agitated. And it can be anything that is sensory similar to a past painful experience. Alternatively, something can activate us to go down out of that window into hypoarousal, where we're just distracted, checked out, and withdrawn. And this is relevant for me at work. I can be walking around calm and comfortable and confident in what I'm doing, and then something activates me to really just push my buttons. And I could definitely lash out, but we are resilient beings. And so I use a series of strategies to intentionally choose my response rather than reacting. And I'll share one of these grounding strategies with you to help bring you back to the present. I learned this from Dr. Eric Gentry. So if you bring your attention to the body from the head all the way to the toes, see if you can intentionally release any constricted muscles. So relax any furrowed eyebrows or tension in the jaw. Allow the shoulders to drop. Release any tension in the hands, and just notice how that makes you feel. That's using the body to communicate to the brain that it's okay to interrupt that threat response. We are no longer in danger, and we're going to come back into our window of tolerance. So number 3 is to respond by putting trauma-informed measures into practice. And for this, I'd like to discuss some communication examples. Communication should be easy to understand, no medical jargon, like you're not going to palpate the patient, maybe you'll press. You're not going to percuss, you're going to tap. You're not going to auscultate, you're going to listen. Use patient-preferred and gender-affirming language that aims to minimize the power differential that totally exists between you and the patient, whether you like to acknowledge it or not. Accommodate people who speak other languages, aim to address social determinants of health, and focus on their strengths. What's strong with them? What's right with them, rather than what's wrong with them? So I'd like to share an example here of our written documentation and how communication matters, especially as patients have access to their medical records and they're seeing what you are writing about them. This is a one-liner that I've written hundreds of times in my life. Mr. Thompson is a 48-year-old homeless man with a history of medical noncompliance and alcoholism who's here with poorly controlled diabetes. So let's just pause and think about the words that I've written and how this might sound to a patient who is reading what we're writing about them. What might be an alternative way of saying homeless man? Can anyone offer a suggestion? Alternative words for homeless. Unhoused. Housing insecurity. Perfect. Those are alternatives. What about an alternative to medical noncompliance? Non-adherent to current treatment recommendations, something like that. What about alcoholism? Substance use or alcohol use disorder, and then poorly controlled diabetes. Yeah, not well controlled, not at goal. You can state their A1C. And so these words definitely make an impact. And What we write in the chart gets copied and pasted and shared by everyone else in the chart, becomes a permanent feature of their records. And when we say this out loud, it also feeds thoughts and feelings about the patient into the brains of the people we're communicating with. So 4 is to resist, actively resist re-traumatization. And for that, I'd like to focus on the physical exam, because as a PCP, this is the riskiest thing that I do. I don't do knee arthroscopies, I don't do lumbar punctures, but I do touch people. And I can absolutely trigger a threat response and make them feel newly traumatized or re-traumatized. When I say re-traumatization, I mean that people can feel that the brain recognizes something that makes the body feel that they're actively in danger, and it can bring back feelings of a past trauma, just as if you were reliving it in the moment again. Sometimes the patient may be aware of it, and sometimes they might not, and all that you're seeing is these behaviors. Re-traumatization can look like fear, and what you're seeing is just anxiety, constant communication with the healthcare team. I have this symptom, I have that symptom. It can also turn into rage, and what you're seeing is anger and irritability. It can be a lot of things, particularly relevant for physical exams and procedures. So what I'll share with you is an abbreviated version of my framework for a trauma-informed physical exam. This is a guide. These are suggestions. This is not standardized, it's not required, it's not a checklist, you don't have to do it all, and I encourage you to experiment with this and find out what works best for you. So before the exam, make sure that your nonverbal communication is exactly how you would like it to be. Ensure that you're at eye level with the patient, that you have a warm, welcoming demeanor, no sudden movements or loud noises, and keep your hands out of your pockets so that it's clear what you're about to do with those hands. I remember teaching a medical student who had lived in a war zone, and he told me that when he sees hands in pockets, he thinks, what weapon are they holding? Set an agenda for the visit. I even name the body parts that I'm going to examine sometimes. Maybe we're going to listen to the heart and lungs, because a lot of my older male patients wonder if they're going to get a rectal exam when they come in to see me. So just getting that off the bat, just nope, we're not going to do a rectal exam. Make it standard. This is something that we do for all patients who come in with their annual visit. Identify what, if any, concerns they have. You can even ask, have you had difficulty with this kind of exam before? Is there anything you'd like me to know? Ask what you can do to help make them more comfortable, and then finally offer a chaperone. So historically, most institutions have mandated the presence of a chaperone for a cisgender female patient who is undergoing a breast, genital, or rectal exam. But 99% of my patients have always been male, and they're the ones who have taught me about the impact of sexual violence. So this is a call to think more broadly about this. In addition to a medical chaperone, you can invite the patient to bring in a loved one or support person during the exam. And if it is a sensitive procedure like a pelvic exam, they should be behind a curtain. During the examination, we attend to patient draping and comfort at all times. What's an example of that? I like asking the patient to move their own clothing or draping rather than me reaching to do so. Like, I can ask them, could you lift the shirt from the back so that I can get a more accurate listen to the lungs rather than me pulling their shirt up, right? Introduce each exam component and explain why it's being done. This is being done for medical reasons, not just because, not for fun, not because I want to look at your body and touch your body. Ask permission before touching the body and or moving clothing or draping if the patient is unable to do so themselves. Stay within their eyesight while also respecting personal space, and I'll show you some examples of this. Use simple clinical language. I'll also show you some examples of this, and check in with the patient periodically and as needed, making sure that you're efficient with your exam. In terms of efficiency, be mindful when checking blood pressure, as it can resemble a restraint, making sure that you are deflating the cuff swiftly. And if you do need to repeat it, make sure that you check in with the patient first. And then avoid any exam where the mouth is kept in an open, fixed position for a long time, because forced sex and sexual maltreatment is an important and under-recognized reason of avoidance of routine dental care. So here's some photo examples. In the first picture, I got to listen to her lungs. Okay, so maybe I'll just stand behind the patient, posterior lung field, but she doesn't see where I am or what I'm doing, and that can be a little unnerving. So in the second photo, I'm standing at her side within her peripheral vision. The stethoscope is long enough, so I still get the data that I need, but it perhaps is more safe feeling for the patient. In the first photo, for generations, doctors like me have been trained to examine the thyroid by standing directly behind the patient and wrapping my hands around their neck with the thumbs in the back. And this can simulate strangulation. So why not stand at their side with the fingers fully extended on the neck and let the patient know what you're about to do and why. Here I'm checking the patient's pulse, but my hand is a little close to her groin, so I can ask her to extend her wrist onto her knee or have it resting on the exam table next to her. In the first photo, this always brings back memories of being an awkward medical student, having such a hard time checking blood pressure, but I'm pressed up against her knees. She's leaning to the side, trying to support her own arm. We're in this unintentional embrace. But in the second photo, I'm standing outside of her personal space. I'm supporting her arm. She has room to breathe and look at whatever she wants to look at, and it just feels better for everybody. In the first photo, a 100% completely supine position is a subordinate position and can activate memories of prior abuse. Consider elevating the head of the exam table slightly, maybe 10 degrees, maybe 15 degrees. You can offer them a mirror for the things they can't see. There's even a movement towards self-insertion of specula for a speculum exam, self-insertion of swabs for a non-speculum exam, self-insertion of ultrasound probes for a transvaginal ultrasound. The tech can tell the patient, please insert this as you would a tampon, rather than them inserting the probe for them, right? That makes a big impact. And even you can offer the patient to collect their own guaiac sample rather than having the clinician insert their own digit into the rectum. Let's think about trauma-informed language. The first word that perhaps may be surprising, that may not be trauma-informed, is the word your. I like to refer to body parts as the during the exam. It feels very different to hear, now I want to look at your penis, versus I will now inspect the penis. The means that it's an anatomic body part that I'm going to check. Like I've examined hundreds of other such body parts. It's less personal and zoned in on their body. It's a little bit more detached. Instead of saying a bed with a sheet, which can frame the exam in an unwanted, intimate manner, this is an exam table, and this is the drape. We want to make sure that we're using inclusive terminology, particularly during exams of reproductive organs. So instead of saying things look normal with your body, everything appears healthy. Stirrups can resemble a restraint, and foot rests, think about it, that communicates a very different feeling to the patient about what they're about to do with their feet. Don't let me, push me away, relax, put up your arms like you're going to fight. These are phrases that I've heard a lot during the neurologic exam when we're testing motor function, but it puts the examiner in this adversarial relationship with the patient. There's conflict here in our words. So just refer to the motion itself. Resist this motion and keep the arms up strong. Push forward, give them control over their own body parts, allow the knees to relax, and then bend the elbows. For me, is a phrase I hear constantly throughout the medical profession when we give instructions to patients, but it can enhance the power differential that already exists between the examiner and patient, and can even be sexually suggestive and inappropriate. Hop on the bed for me. Take off your shirt for me. Bend over for me. Swallow for me. It's just not a necessary phrase. Here's some sample language. I'm going to press on the front of the neck to check the thyroid gland. When you can, please swallow. So now we're into after the exam. You can thank the patient for helping you conduct a thorough exam. This is a meeting of two experts. It's a collaborative team effort. Discuss results, but only once they're dressed in their regular clothes and seated at a chair of their choice, rather than perched up half naked on that cold exam table. And then finally ask for questions. And rather than asking, do you have any questions? And they're going to feel pressure to say, no. Just like if you see a friend in the hall and you say, hey, how are you? They feel pressure to say fine, even if they've had the worst day of their lives. So I stop what I'm doing. I turn my body to the patient. I make eye contact and I say, what questions do you have? It lets the patient know I expect you to have questions and I welcome them at this time. So this is a summary slide of what we've reviewed so far for a trauma-informed approach to the exam. Before the exam, setting a sensitive stage. during the exam, making sure that you're practicing with sensitivity, and then closing in a sensitive way as well. So let's think about how we can apply trauma-informed principles to ourselves as we are in this minefield, a very difficult profession to continue to adapt within. And these are terms that we've heard through the years to explain clinician suffering, and the alphabet soup is ever increasing. We don't have a great understanding yet of all of the distinguishing features between all of these terms, but what is at the core is that no matter what we call it, we do need to attend to health worker suffering. I like this photo because it reminds me of what I experienced in my psych rotation as a medical student. I was somehow thrown into doing group therapy sessions without any prior training or warning. I was absolutely not in the right position to do that. But I had a very hard time listening to these stories that patients shared. And I asked the attending, how do you do this? And she basically described herself as, she sees herself as a vessel. And the more she attends to, the more she bears witness to, the more she hears from her patients, the larger that vessel grows. And she is more grounded and equipped to provide care for the next person. I thought that was beautiful. So thinking about the term wellness, which we have repeated several times today, there are many models for the dimensions of wellness. This model is also from SAMHSA, and I'll just provide a trauma-informed tip for each of these dimensions before we close today. So the first is intellectual. I had the once-in-a-lifetime experience of speaking with the Dalai Lama via Zoom in this meeting that we had at Harvard. And his main message was that the brain controls the health of the body, and that we can control the health of the brain. And compassion is the key to healing ourselves from prior difficult experiences, and the key to helping others do so as well. So the brain is a very, very powerful organ, and we can destroy ourselves replaying negative thoughts. We often live in one of two places. We're either in the past, where we're ruminating about the horrible things that have happened to us or others, or we're in the future, where we're ruminating about the horrible things that are about to happen. But we're hardly ever right here, right now, in the present. So observe your thoughts, edit your thoughts, delete thoughts that don't serve you, and insert ones that do. Physical well-being. Moving the body is crucial for healing. Did you know that yoga can be a more effective treatment for PTSD compared to any medication we've studied? I have many patients who spend 1 or 2 hours in the gym every day as the core piece of their mental therapy treatment. So please consider that for your own lives. Environmental, if you observe the workplace environment in which you work, how does it make you feel? Does it calm you down? Does it stress you out? There's actually a thing called trauma-informed interior design, believe it or not. And some key tips are making sight lines clear, organizing any clutter, bringing in real nature or photos of nature, having natural light if that's available to you, and using cool tones like blues rather than warm tones like red or orange. Financial. Most of us, to some degree, have a scarcity mindset when it comes to money. There is never enough of it, right? But taking some kind of control can help with this feeling of worry. And maybe that means looking at what amount of money you actually need to live the life that you want, spending money on your priorities, and making plans to help your money grow. For occupational, how many of us went into healthcare because we were transformed by some adversity earlier in life? Trauma by nature is transformative. It changes your worldview, it throws things upside down. But there is this concept called post-traumatic growth. Dr. Richard Tedeschi is the pioneer in that field. And if we're able to use our adverse experiences as fuel for growth and innovation, that's where the magic lies. And that can be done with time and with help. Social, this is probably from a trauma-informed lens, the most crucial circle of wellness, because healing happens in relationships. We are humans built for connection. And in the post-pandemic aftermath, isolation is still impacting society. So spend time investing in healthy relationships and make new ones, and encourage your patients to do so as well. emotional. For this circle, I'd like to focus on the power of sleep as emotional regulation. Many of you have heard, just sleep on it, you'll feel better in the morning. And there's actual science behind that, because sleep can biologically soften the rough edges of a stressful event. You'll wake up in the morning remembering the events that happened, but it won't be as emotionally charged. Spiritual studies of highly resilient groups of people find that they usually have some inner calling. They believe in some greater power. They're very mission focused. And so I encourage you, as best you can, to remember why you went into healthcare to begin with and intentionally reconnect to that inner purpose. What we do is really hard sometimes, and here's some closing tips. As best you can, focus on what you can control rather than what you can't. You don't have to be a therapist to be therapeutic. Everybody has the potential to heal themselves and participate in the healing of others. Trauma-focused treatment is for licensed mental health professionals who dive into trauma histories and aim to mitigate trauma-related symptoms. Trauma-informed care is for everybody, where we're just mindful of establishing a healing, safe, empowering environment. Use grounding techniques for yourselves, and you can actually model it for others. I model grounding techniques for patients all the time when we're talking about panic or anxiety or PTSD. In the room, I actually ask the patient to put one hand on their chest and one hand on their abdomen and notice which hand is moving, because when we're feeling stressed out, we usually have fast, shallow breathing and our chest wall is moving. But if you take a breath that is so deep and big that both hands move, that also sends a message to the brain that it can interrupt that breath response. And patients don't have to use their hands to breathe when they're at work. This is something that can be done surreptitiously, hundreds of times per day. Next, you can start or end the day with a practice of gratitude. We've probably all heard that this has been shown to increase the perception of a happy life. Don't feed or replay negative thoughts. Let them die a natural death. This has been huge for me. I'm someone who is an empath at heart and definitely identifies as a healer. And the things that I've been witness to in my life and in my clinical practice, especially with veterans, has been disturbing on many levels. And so I've had to learn hard over the years how to not replay these images and stories and negative thoughts. Is it serving you? Probably not. So let it be. And sometimes being present is enough. We can't fix the past for people. We probably can't take away all of their pain, but we came into this profession with the power to be present, hold space for people's emotions, role model empathy in perhaps a way that they've never had it role modeled before, and provide care. When we're thinking about adversity in childhood, all it takes is one caring adult to help that child develop resilience to move past their adversities. And that caring adult does not have to be a parent. Similarly, you can be that person for your patients. So in summary, trauma-informed care is an established framework for supporting people through significant stress, and it's a growing movement in this time in history. That these practices can be applied universally in all clinical interactions, including communication and physical exam. And this practice can absolutely contribute to a more meaningful experience for both patients as well as me. It has absolutely transformed my practice and my world, and I hope that it is the same for you. So I welcome your comments, questions, and suggestions. There's a lot of wisdom and expertise in this room. I thank you for your time and presence today. And if you'd like to continue the conversation, you can just Google me or contact me through this website. Thank you all so much.
Anyway, I thought that was outstanding, and thank you so very much
Thank
for doing this. By all means, are there any questions? We'll get this working real quick. Any questions? Sure.
Or recommendations, suggestions, of observations from your own practice.
Can I have a few announcements? Well,
Okay.
we do have one. Thank you.
No. No. Thank you for your courage in sharing that today, because that is brave and not easy. And you're right, that is a toxicity of the culture in which we work, and something that is truly wrong with society that we are hopefully working towards shifting. And now, Google searches for trauma have never been higher than they are today. Mental health awareness is rising significantly. People are very comfortable talking about it. I gave a talk at a tech company in Boston this year, and it was all 20-something-year-olds in the audience. And afterwards, they're like, "Oh yeah, we have Trauma Mondays where we talk about our trauma." They were totally aware of all of the literature, and like they're on their Instagram feeds about survivorship, and yeah, we can learn from that. So I think healthcare is behind in many, many ways, and we need to establish systems that are trauma-informed throughout. There's a growing interest now in trauma-informed workplaces, trauma-informed leadership. So I've been involved in some of those publications and trainings. It's an exciting time. You did nothing wrong. And what we need is for the world to hold you and for the world to hold us. And this is a work of love.
Other questions?
Pandemic that has exploded since the pandemic.